Good evening, everyone. Welcome to our 62nd Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Iheno Taddele, a general physician and first aid trainer from Blue Health Ethiopia. Today's seminar is presented to you in collaboration with HBG Medical Assistance. Today, it's a pleasure to have Dr. Sonia Malik here with us to give a seminar on in vitro fertilization and infertility. Dr. Sonia Malik is one of the pioneers in the field of infertility in India. She is also a veteran obstetrician and gynecologist with a specialization in assisted reproductive technology and in vitro fertilization. Dr. Sonia is currently working at Nova Fertility and is the Chief Clinical Director. So, Dr. Sonia, the stage is all yours. Start.
Thank you very much. Good evening to all. Good evening to everyone who is here today with us. I would first of all like to thank all of you for being here and of course the organizers for giving me this wonderful opportunity to interact with all of you. With this, I share my screen with all of you and I should be speaking on the evolving technologies of IVF and infertility. So that is, of course, so I represent Nova IVF Fertility, as has been told to you, and the Chief Clinical Mentor. We have 74 units across the country, and I am the clinical mentor for all of them. So here is what I'm going to talk about, the clinical advancements in ART that have improved the pregnancy rates. As you can see over here, we are very proud to say that we have achieved about 75,000 clinical pregnancies in Nova across our centers in the year 2000 by the year 2023, and these are going to go on improving as we go ahead. So what should we talk about ART success rate? Look at this chart which tells you from 1997 to 2009. These are basically analysis from the European Society of Human Reproduction and Escherichs monitoring unit. And of course, it shows that, the pregnancy rate live birth rate has been somewhere between 28 to 35% all the time. And of course, per treatment cycle, it was 27.1% in IVF and 24.3% in ICSI in the year 2016, which is not very old. So you can see from here that the clinical pregnancy rate has not improved a lot, but yes, we should go ahead and see what is happening to the advances in ART to understand whether it is really true or are we really increasing our success rate. So then we will see that innovations have started to happen both in the clinical management side as well as the embryology laboratory, which are continuing to improve our pregnancy rate. And concurrent with these innovations and advancements in IVF, we have seen the emergence of related technologies also, just as genetic testing, oocyte preservation, and they have actually broadened the application of this technology to both the fertile and infertile couples. So what you can say now is that IVF is not just meant for infertile couples, it has been extended even to the fertile couples who would want to preserve their fertility. So therefore, many innovations and advances in ART have increased the success rate and offered a broad range of options to couples who are undergoing treatment. That is very, very important because now we can select what we want. It's just not one thing that is available. It's a bucket or a basket of so many technologies that are available, which are actually helping us to select them. And that is very, very important for us. So technological innovations have been developed and they have potential to change the field of ART in very exciting ways well into the future. And as these relevant applications of ART become increasingly utilized, we will have to also understand that we are somewhere morally responsible to use them carefully and wherever they are required, not use them at random for everyone, so that, instead of causing a benefit, we are not harming our coming generations. So that has to be very well understood, that we have to use them in a manner that they do not change the society for worse rather than making it better. That is important for us to understand. So what are these cutting edge innovations in the field of ART, and what are the implications of these technologies to the future? As you can see here, these artificial wombs have been formed, now, we know that there have been the birth of animals like sheep, etc. from here, from these uteruses which have been formed for the wombs, artificial wombs. So the time is not far away when we would be having these in our ART labs as well, where you will have the full-fledged baby coming out of them. So what is the first major advance? It is this which has enabled you and me to connect and talk to each other. This has been the biggest advancement in ART as well as in any other field of technology or any other science, where we are able to connect to anybody across the world and effectively trying to get hold of what is happening at the other side of the world, and thereby improving our performances also. So it was a major boon of COVID, I would say, where all of us connected together, and we did find that we could do most of our work by doing connecting with each other over the internet. And you can see over here, this was an embryo transfer which I was witnessing over Zoom, and this was being done in my OT, and these are lectures, of course, you can see. So all kinds of things are possible, and teleconsults have become the fashion of the day. So also what is important is data. We all understand the importance of data now, and we know that data means a lot of information. Therefore, strict SOPs, patient records, procedure records, auditing of the procedures, center management, and linking multiple units has become the order of the day. We are all now strictly connected by all these things in order to perform better. Because if you have SOPs and if you know your patient's records well, you can definitely offer them better procedures, better outcomes once you know what happened, what went wrong in the last time. So also, by connecting multiple units, as we have in NOVA, where all our 74 units are connected to each other through a software. And therefore, what happens is that if you have a patient coming from, say, Mumbai to Delhi to me, I would know her record immediately by clicking on that. And that is not something that, you don't, sorry for that. So basically, these are the things that have actually changed the management of ART also, as it has for other science subjects. For us also, it has helped us to achieve better management of our patients. So what about the clinical advances then in IVF? There has been a better understanding of the physiology of reproduction. There has been a development of new protocols. The concept of individualized controlled ovarian stimulation, I shall talk about this to you just now, and basically prevention of multiple gestations by just transferring one single embryo, the new drugs and formulations, vitrification, and the concept of freezing all embryos in order to prevent ovarian hyperstimulation, and then the assessment of recurrent implantation failures. You have so many patients who are just failing one after the other in IVF, and basically you need to understand why this is happening. And then extending the services, IVF services, to other specialties like andrology, like oncology, genetics, and like I said, normal couples even. So basically now it is not just infertility, it is beyond infertility that we are offering all this. And therefore, it will significantly improve the cost and safety associated with IVF in the coming years, because basically we have got now a better understanding of the whole process and a better understanding of how we should clinically manage our patients. And then, can we therefore define the best patient? We all know that we know the best embryo, we can define the best embryo, we can define the best sperm, the best oocyte, or even the best lab. So what are the parameters which would define the best patient? And that has not yet been explored. We are still trying to see how to find who is the best amongst all of us. And in 1976, WHO actually described 3 groups of women according to the ovulatory dysfunction. And when you have to stimulate these patients, all the women, you put them into different categories whereby you understand and know how to stimulate them. And so the group 1 was basically hypothalamic pituitary failure, where there was amenorrhea because there was decreased or normal FSH or NLH, and prolactin was also normal. However, in the second group, hypothalamic pituitary dysfunction, this is the largest group that is found in our clinical practice. There are menstrual disturbances like amenorrhea, estrogen is present, normal FSH and prolactin. However, there might be increased LH and hyperandrogenism. Hence, this group is basically the group which has PCOS, which has endometriosis, which has pelvic inflammation disease. So this is the largest group that we have. The hypothalamic pituitary is the hypogonadotrophic hypogonadism that you find in some patients where they have no gonadotrophins of their own, and therefore they have to be stimulated by giving them extra gonadotrophins. The third group is the hypergonadotrophic or ovarian failure group, wherein again you have amenorrhea, but then the FSH is increased and the LH is increased, which means that the pituitary and the hypothalamus are performing properly, but the ovary is not responding to them. Here it was central, where it was the failure was at the pituitary and hypothalamic level. In the third group, the failure is at the level of the ovaries. And this also has a subgroup where there may be a failure of the end organ, that is the uterus. There may be no uterus or there may be a non-functional uterus. So you have this third category where you will have either the end organ failure as far as the ovary is concerned, or you may have end organ failure where the uterus is concerned. So these were the third groups in order to define the best patients, or in order to define which patient would you like to treat. Because basically, if you have a woman who is absolutely normal, she's ovulating, she will not fall into any of these categories. However, she is still not conceiving, maybe because there is a male infertility problem, or there may be a couple of unexplained infertility. Hence, this was what was described earlier on. So let us see how we have progressed to what we are now. We have gradually understood the reproductive physiology over these years by stimulating these kinds of patients. And we have understood that there is a finite number of oocytes. It's not as if there is an unlimited number of oocytes that are there. And basically, what is happening? Sorry for this. So it isn't as if we have, there are lots and lots of eggs and we can make use of all of them. The basic problem that we need to understand is that every egg does not have the capability of giving rise to a pregnancy. This is a very important point that we all need to understand, because many a times these patients come to us saying, I'm forming an egg every time. When I go for follicular monitoring, they tell me that I have an egg, and yet I'm not conceiving. So we have to understand that all oocytes do not have the capability of giving rise to pregnancy. Otherwise, the natural fecundity also would have been 100%. But we know that naturally also women conceive to the tune of about 25 to 30% only in a given month. So if 100 women try for a pregnancy in a month, they all do not conceive. And this is the reason why they don't conceive, because every egg that is released by them is not capable of giving rise to a pregnancy. The third important thing that we have understood is that endocrine manipulation can be done throughout the menstrual cycle. That means that you are not now, earlier we were restricting ourselves to giving hormones only in the beginning of the cycle. However, now we have understood that with the help of hormones only, we can manipulate the ovarian cycle and the uterine cycle at any given point of time in the menstrual cycle. And this is what has given rise to what is basically now understood as the new protocols. So stimulation can be started at any given time in a menstrual cycle. I will describe it to you. And every individual behaves differently based on many factors, both intrinsic and extrinsic. That is a very important point to understand, where we are describing the best patient. So best patient means every individual is different. We all know that, because our faces are different, our internal organs are different, everything is different. Hence, even for ovarian stimulation, every patient and pregnancy, every patient behaves differently. And this is what is called ICOS. That means individualized controlled ovarian stimulation in order to achieve pregnancy in every patient is now essential. So we are not going to stick on to the earlier protocols. Okay, this is what, just give her 1, 2, 3 and she is conceiving. No, it's not like that. It is more of magic now. You have to understand the patient now and then give her the treatment in order to have a better success rate. So then what is ICOS? So we have realized that even within these 3 WHO types, the 3 groups, there are many subtypes, and therefore each one of them will require individualized treatment. For instance, I will give you the example of polycystic ovarian syndrome. So PCOS, you know that in PCOS, you have many subtypes depending upon whether the patient is having anovulation and hirsutism, whether the patient is having anovulation and ovarian and the PCOM picture on ultrasound, or whether the patient is ovulating but has hirsutism and PCOM. So depending on the various combinations, there are subtypes within the PCO subgroup only. Hence, the WHO type 2 PCO is also of many subtypes. And therefore, you have to define that subtype and then treat them accordingly in order to get best results. So this is called ICOS. And also with it has come the realization that every woman therefore will respond differently to the same drug or protocol because she is made differently and her hormones are going to react differently. So now women are reclassified according to the response of the patient, not according to these 3 WHO groups. We will now define the patients according to how they respond to the protocol and the drug that we are giving them. And this is what is called from the type of patient to the response of the patient. We defined the patients in these 3 groups, but we also want to see how they respond. And that is based on the number of follicles seen on ultrasound and the number of oocytes that we retrieve. We may see a lot of follicles on ultrasound, but the number of oocytes that we retrieve from that woman may be only 5 or 6. So that depends on basically her response. All of them may not be leading to good oocytes, and that is what I was trying to explain to you. And based on this, we have 3 kinds of patients now: the hyper responders, the normal responders, and the poor responders. In the poor responders, we have 2 subgroups: the hypo responders and the poor responders. I will define them a little later. Hyper responders basically are one that will produce many eggs, more than 15. And the normal responders are one where you will find a normal response from 10 to 15. And in the poor responders, the hyper responders will show a response of up to 9 eggs. And the poor responders will show a response of 4 to 5 eggs only, not more than 5. So that is how you classify the response, and that is how you will classify the type of patient. And then we have devised methods to understand and to actually define this response and see how we find it in our patients. So therefore, we also understand now that the response is influenced by the patient's characteristics herself. For instance, the age of the patient. A person or a woman who is 35 or 38 years of age is definitely going to respond as a poor responder as compared to a young girl who is about 20 to 25 years of age. So therefore, age is the biggest factor which influences the ovarian response in a patient or the hormones of a patient. Similarly, the BMI. Obesity is basically, it decreases the ovarian response because they become stubborn. The fat is very stubborn and it does not let, it has hormones in it which do not let the ovary perform properly. And hence the BMI itself is a very big factor to define the response of the patient. Ethnicity, this is very important. And from your point of view, I would like to say that we find that the African nations, they have a longer reproductive life as compared to our Indian girls. So for us, you will find that people from your continent will be menstruating for a longer time, more than us. So here we find menopause occurring at a younger age, say of 47, 45. But at your place, it is definitely extending beyond that to about 50, 52. So that is the difference between the ethnicity. Then, of course, what kind of addictions the woman has: smoking, alcohol, and drugs. You all know that it is a deterrent to fertility. Other fertility factors, for instance, you have infections, or you have basically tubal disease, or you have endometriosis. So all those also happen, all those also influence the patient's response. Similarly, the genetics of the patient. So suppose the patient has a genetic disorder, then definitely the response is going to be different. A very important point is the past performance of the patient. Suppose she's had infertility treatment in the past and there the response has not been good, one, it makes you wary of it. It tells the treating physician that you have to be very careful in stimulating this patient, because she may not show the kind of response that you're expecting from her. So that is something that you need to understand. Then, of course, there is a risk of drug tolerance to the drug, a risk of tolerance to the drug. Sometimes they do have side effects to the drugs that you give them, and hence they may not respond the way you want them to. So these are some of the features which will help you to see what kind of a response or what kind of a patient is sitting across the table when you're trying to treat them for infertility. Then coming to the diagnostics, the AF, AMH, and now I was saying that we are trying to define the best patient and trying to see what is wrong with this patient in order to first define her and then stimulate her. So the diagnostics that have really revolutionized infertility are basically the ultrasound. That is the biggest armament that we have in our bucket. And as you can see here, this is a 2D ultrasound of an ovary, which is highly stimulated, and you can see that it is hyperstimulated. Here again, you have a beautiful 3D ultrasound showing anomaly, the uterine anomaly. You can see a subseptate uterus over here. You can see over here that there is an arcuate uterus, similarly here, and here is a septum. These are all 3D images, and this one is a hysteroscopic image now. So another thing is, again, if you see the 2D images over here, you can see the difference in these two ovaries. You see here the pearl-like appearance of the polycystic ovary, and you see a lot of stroma. So this is actually going to help you to decide what kind of a protocol you should be able to give to your patient. So diagnostics in the form of ultrasound and diagnostics in the form of molecular tests like AMH have helped us to define the kind of patient who is sitting in front of us. So also, like I said, in diagnostics, the ultrasound actually also defines the kind of ovary that is sitting in front of us. That is the antral follicle count. And depending on how many follicles you find in this ovary at baseline, you can define what kind of response this patient might give you. So then we went a step further. We tried to define the patients according to the response of the patient in a particular group, that is the poor or the hyper-responders. Stimulating the hyper-responders is not difficult. You can, but you have to be very careful that you don't go overboard and you start having, you start seeing, basically you start having too much of a response and ovarian hyperstimulation. But at the other end of the spectrum are these poor or hyper-responders, where no matter what you do, you will not get enough eggs from them. So the Poseidon is a group that defined this or stratified these hyper-responders into 4 groups, depending on the age and the AMH and AFC. So group 1 is a patient who is young with adequate ovarian reserve parameters. That means when you look at her ovarian reserve, you look at the follicle count, and you look at the AMH of this patient, and you look at the BMI, everything is perfect. And so basically, when you stimulate her, there is an unexpected poor or suboptimal response. So group 1 is a surprise, where everything was all right. She's a young patient with everything normal, yet she responds very badly. So if it is less than 4 oocytes, it is basically type 1A. And if it is more than between 4 to 9 oocytes, like I said, that is a hypo response, so it is 1B. Similarly, group 2, again, she's more than 35 years, but her ovarian responses, ovarian parameters are fine. AFC is good, AMH is good. And of course, when you stimulate this patient also, she has an unexpected poor or suboptimal response. So group 1 and group 2 are patients defined by the age less than 35 and more than 35, but showing an unexpected poor response. Whereas in group 3 and 4, again defined by age less than 35 or more than 35 years, the pre-stimulation parameters for ovarian reserve are poor. Here, AFC is less than 5, AMH is less than 1.2. And again, in the older patients, same parameters, AFC less than 5 and AMH less than 1.2, again in these two. So in such patients, you find that the response is poor. So this is unexpected, and these are expected poor responders or hyper responders. So that is how you define this group. And so you find that these are the groups where you can really give them a bit of help, but group 3 and 4 are actually very stubborn to get more eggs from them, and you really have to knock your head and try and find out what best protocol to give them in order to get better results. Can somebody indicate to me whether you're hearing me properly? I don't have any indicator to tell me whether I'm audible or not. Can somebody please tell me? Hello?
Yes,
Hello?
Dr. Sonia, you're audible. You're
Oh,
audible.
all right. So I'll go ahead. Sorry.
Yes,
So
yes.
therefore, unpredictable poor hyperresponse, predictable poor hyperresponse, and of course, then you move on to how you individualize these protocols, how you see whether you can stimulate them or not. And like I said, age, the FSH, AMH, and AFC, these are the parameters by which we assess these various patients, as to how we can stimulate them so that we get a good response. And in PCOS, of course, obesity is there. So we also take care of obesity in such patients. And the biggest parameter for all of us is the poor previous response. If that has been good, we can be assured that we will find very good eggs even here. Now, how do you choose your protocol? Basically, like I said, it depends on what is the AMH and what is the number of follicles that you see over here. These are some of the algorithms that have been defined in literature. And this is quite an old one, which was in 2012 and 2009, but it is still holding strong. You are defining the three kinds of patients: high responders, normal responders, and poor responders. And you have to choose your protocols according to that, depending on the dose also according to that, so that you don't go overboard and you don't have hyperstimulation, or you don't stimulate enough and you don't find eggs. So you have to be proper in what you do. High responders with 150 IU, normal responders with 150 to 225, and the poor responders above 300. You can also give up to 300 or more than that. So if you look at the prevalence, this was a paper which we published some time ago, and we found that in this group of Poseidon, 218 patients, group 1 was 42.6% and with a pregnancy rate of 27%. Group 2 was 27% with a pregnancy rate of 19%. And as you can see, the group 4, more than 35 years of age and having poor response parameters, the pregnancy rate was also low. It was to the tune of only 11%. So this is a kind of expected result which you would find in such patients. In the older age group, you will find a lesser response, and in the lower age group, you will find a better response. So the earlier you tell your patient to go in for IVF techniques, when they especially have poor ovarian response parameters, poor ovarian reserve parameters, then it would be easier for them to have a pregnancy. So now, what have we done to improve the outcome of ovulation induction in our patients? We have actually talked of individualized ovarian stimulation. We have started to use natural or modified natural cycle in patients where we expect not more than 3-4 eggs. There we don't want to push them with too much of hormones, because it doesn't make sense giving them a huge, long, very, very high dose of hormone and then getting only 2 or 3 eggs. So therefore, this is used as natural modified cycle. Then we do a mild stimulation. We also use long-acting FSH, double stimulation, and random start protocols also are being used for some of these patients, especially for patients who are coming to us from other countries, and they are coming at any time during the cycle. Like I said, we have now understood that we can start the ovarian stimulation at any point of time. So for them, we have these random start protocols also. So some of the new protocols are basically, these are the ones that I will describe to you. Random start, because it involves people who are coming from your country. Duostim is for patients who are giving us very, very few follicles. So we do a dual stimulation in them. Accubate is accumulation of follicles or oocytes over multiple cycles, which is also being done for poor responders as well as poor ovarian reserve patients. And of course, minimal stimulation, where you are not expecting good results. Say she's over 35, ovarian reserve are very, very poor. So in those cases, you just give a minimal stimulation. So what is duostim? So what has happened is that we have now found that in a menstrual cycle, the ovary throws follicles not once, but twice or even 3 times. So within a cycle, there may be ovulation 2 times or 3 times. This is what has been discovered because of the presence of the ultrasound now with us. So what we have done is to make use of this. We do 2 stimulations. one in the follicular phase, which is the actual phase starting from the second day of the cycle. And then you do a retrieval, say once the egg is mature, you give a trigger and you do a retrieval. And then after that, you start the second stimulation in the luteal phase. You start stimulating again in the luteal phase. So within one cycle, 1 month, that means within 1 month, you can do 2 stimulations and collect many more eggs. Every extra egg gives rise to a 5% extra success rate. That is what is known now. Hence, the magic number is 15 eggs, which gives us the best pregnancy rate in any patient, in any given patient. Now, you can't expect a 38-year-old or a 48-year-old, 40-year-old patient to produce 16 eggs. Therefore, you start doing protocols like this, where you're stimulating them twice and getting more eggs in them. And this was one of the first papers which came from Ubaldi's unit in 2015, where they have done follicular and luteal phase stimulation. And they have found that the number of clinical pregnancies, miscarriages, ongoing pregnancies were the same in both the groups, and hence concluded that whether you do 1 or you do 2, you will collect more eggs and you will get a better cumulative pregnancy rate, because basically you are getting more eggs out of this patient. So here were also, when they did a PGT in these patients, they found that patients with no euploid blastocysts had, and there were patients with more than 1 euploid blastocyst, as you can see over here. So you can see that in the follicular phase and in the luteal phase, nearly the same number of normal euploid embryos were found, giving a good cumulative pregnancy rate of euploid embryos to the tune of 30%. So this is our paper where we did it some years ago and got a pregnancy in this. So what is accuvit? Accuvit is actually the accumulation of many oocytes. You keep on doing multiple cycles. For example, this cycle, as I have shown over here, you give letrozole, HMG, then you give an antagonist and trigger. You do an OPU, and then you do a oocyte freezing. So you do multiple cycles like that, and you keep on collecting the eggs. And finally, you do an ICSI and you do an ET for them, because basically then you have an adequate number of eggs, like I told you. So when they have found that basically there was really no difference between the two, this protocol, wherein you are collecting the oocytes and then doing it from the vitrified oocytes. You are doing the embryology and getting good blastocysts out of that. So therefore, this is a very good method, again, for patients who have a very poor ovarian reserve. So you keep on collecting their eggs, completely forming blastocysts and then transferring them. So we also did that. And so therefore now the next step in basically the next innovation or advancement in technology is individualized luteal phase support also. That means we were talking of stimulation. Now we come to the second part. After that, once you have transferred the embryo, what happens? Here also, we have understood the luteal phase better, and therefore we are also individualizing this luteal phase. So what we have also found is that now, instead of 1 type of trigger, we have 2 types of triggers, rather 3. So the conventional trigger, which you all know, when you are doing IUIs, you're giving HCG as a trigger, and then you're doing an IUI. So for those who are doing IVF, you give an HCG and then you collect the eggs. Now there is a second kind of trigger, which is the GnRH agonist trigger, which is given in patients where you are suspecting hyperstimulation. In those patients, in order to prevent hyperstimulation, because HCG causes hyperstimulation in these patients, you don't give an HCG, but you give a GnRH agonist. But the downside of GnRH agonist is that the luteal support is very, very small. It rises sharply and falls sharply within 20 hours. So you find that this long period of waiting, where you're looking at the luteal phase, this is a long period which is absolutely without any hormones, without any support that we were getting, say, from HCG. HCG, on the other hand, is giving a longer period of support, say up to day 6 after it has been given. But GnRH is only lasting for 48 hours, not more than that. Hence, this luteal phase has to be supported very strongly in order to get a good pregnancy rate. So what works then? What works? You have to give progesterone in all the cases. You have to, because in GnRH agonist triggers, you don't have any progesterone happening from there, because there is no support to the corpus luteum. And especially in the frozen embryo transfer cycle, you don't find anything. So therefore, Progesterone has to be given to all. Route and dose is variable. More than one may be beneficial. Optimal time for beginning the progesterone is absolutely vital, and stopping progesterone is variable. So HCG can be given in some cases. That is the second thing that we give in the luteal phase, where the risk of OHSS is minimal. Low dose regimens can be given selectively, and of course, it is generally stopped when there is time for luteoplacental shift, which is about 7 to 8 weeks. What does not work at all? You may have found many prescriptions in your country where lots of adjuvants have been given to support the luteal phase, for instance, aspirin, favipiravir, and then you have these antioxidants which are given, and then many more things, RG prime, and of course, sildenafil. So these things are all adjuvants which are given, but they do not seem to be having any effect on these cycles. So it is better to avoid them because it only increases the cost to the patient. So what about now coming to the second part? So this much is for the female. Basically, we have tried to define what should we do for which kind of patient, what is the response that we get from the patients, and how can we collect the maximum number of eggs for each patient in order to get the best results. What about male infertility? What are the advances that have happened in male infertility? The prognostic value of semen components such as the sperm number, motility, and morphology as surrogate markers of male infertility may be confounded in several ways, because this is the only thing that we look at. We look at the sperm number, we look at the motility and the morphology, because basically the fertility potential of a man is actually influenced by the sexual activity. So this is something that we are finding new in our patients now. Many of these boys who are working for IT companies, or many of the people who are working abroad and have to keep on traveling up and down, are hardly ever present together with their wife, and hence, it is falsely judged that this couple is not fertile, because basically they haven't been able to produce a child. But actually, there have been long periods of abstinence in both of them, which is actually the cause for this infertility. The second is a function of the accessory glands, which may be defective, and many a times this is missed because you do not do the culture of the semen many times, and you don't see any infections. You don't look for infections over there. So this is something that must be taken care of. And of course, we also need to understand there are sperm dysfunctions also. As you have the ovary producing dysfunctional eggs, you also have sperm dysfunctions, which may be because of a fragmented DNA. So therefore, these are the new things that have come up now. So this has led to more scientific understanding of the endocrinology of the male reproduction, the role of genetics in male infertility, and functions of each cellular component at a molecular level. So therefore, there have been advances to treat male infertility also. So what about sperm function? You need to deliver an intact DNA into the oocyte. So the intact chromatin is critical for the production of a viable pregnancy, and DNA is a manual of instructions. So what are the lesions which may be associated with sperm DNA fragmentation? It could be a single strand DNA break, or it could be a double DNA break, as you can see over here. If it is a single one, it can be corrected by the oocyte, but if it is a double break, then it is not corrected easily at the time of fertilization, and the patient can have problems, and the embryo can be malformed. So basically, the clinical implications are: first type of damage, or a single strand, is reversible and can be repaired by the oocyte or embryo. However, the second type of damage, which is irreversible, manifests ultimately leads to errors in transcription and translation and mutation. So basically, this could present with miscarriages or an abnormal child. So causes of DNA fragmentation is something that all of you must understand, because this is not something which is not difficult to understand. There are three kinds of causes for DNA fragmentation as well: the pre-testicular, the testicular, and the post-testicular. The pre-testicular could be age. It is something which is coming up now, that it is not just the age of the female, it is also the age of the male partner, which is responsible for pregnancies and or good sperm parameters. And if you have a male partner who is old, then you may find a problem in conception. Smoking, high BMI, diabetes, cytotoxic effect of chemotherapy and radiotherapy. What about testicular causes? Now, if there is really something wrong with the testes itself, there is some problem over there, this obviously is going to lead to DNA fragmentation. So varicocele, genitourinary infections, increase in immature germ cell concentrations, and lycocytospermia. So basically, these are some of the causes which may influence the performance as well as the pregnancy outcome. What about post-testicular? Post-testicular could be obstruction at the level of epididymis, vas deferens, long periods of abstinence. So here is what I was referring to, long periods of abstinence, which leads to DNA fragmentation and hence can be the reason for recurrent pregnancy losses or recurrent implantation failures. So please be careful of what kind of a testicular damage this patient has, and depending on that, you have to treat them. So this is a new terminology that has now come in called MOSI, which actually tells you that there is a male oxidative stress infertility, which means that there is about 30 to 40% of oxidative stress amongst men. And this leads to unexplained infertility in the man. And basically, it is responsible for a lot of male factor infertility, because what we have found is, despite there being such good methods like ICSI and its offshoots, pregnancy rate in male factor infertility hasn't become very good, which is because we had not been able to define this factor, this of male oxidative stress. So be careful if your patient is smoking heavily or is having drugs or is having any such things. So then you should be able to warn that person and take him off that so that the oxidative stress is decreased. So this was a classification that was proposed, and it came out as one of the review articles in Men's Health Journal and led by Dr. Ashok Agarwal from Cleveland Clinic. So what has been found is basically that in normal semen analysis, when you do it, WHO results, according to the WHO result, there was about 36.4% of patients who do have an elevated sperm DNA fragmentation in such patients. This new book released by WHO on sperm parameters has now suggested that in the next edition we would probably be including this DNA fragmentation as also one of the indicators of semen health. Till now, it has not yet been included as one of the parameters. Now, we also did this in our own clinic, which was Southend at that time, and we found that if you have the mean DNA fragmentation was about 31.3% also in our patients. As you can see, this is a test which is done very commonly. It is basically a dispersion analysis and SCD, which is called SCD. So basically, you find that there is it is known as the halo test. You find a little halo over there, which is a normal, and the abnormal is without any halo around it. So that is how you pick up semen DNA fragmentation. These are the 4 methods which have been described in literature. And you can see over here that some of them are very difficult. The SCSA is the standard, but it is an expensive equipment and it is not available everywhere. So how do we reduce this sperm DNA fragmentation? Either you can give antioxidants and lifestyle changes, like I told you, and the other one is to treat the underlying condition, and of course, to avoid iatrogenic sperm DNA fragmentation. I will tell you how. Basically, antioxidants and lifestyle changes are something that we all must know and advise our patients, because we have to decrease that oxidative stress. Treatment of the underlying condition, for instance, the patient is having a post-testicular, that means that they are abstaining for a long time, that needs to be corrected. So the rationale for giving oral oxidants is the antioxidants was basically that oral antioxidants are actually reducing the oxidative stress in the testes and its pathway and in the tract of the male reproductive system, and therefore it is helping to reduce the oxidative stress and hence the DNA fragmentation. So the next thing is that if it is not helping, suppose you have given it for at least 3 months, you have to give a short-term use of the antioxidants. I do not know how these lines are appearing on the screen. Somebody seems to be scribbling. Anyway, so we have to caution against indiscriminate use of high doses for very long periods, because this is a self-perpetuating kind of a problem. Antioxidants themselves, if given in high doses, can lead to oxidative stress. So you have to be very careful and give it only for a period, say about 3 months. And if it is not helping your patient, please look for some other cause. Do not use the same thing again. We published a paper wherein we looked at the daily ejaculation, the role of daily ejaculation in improving the DNA fragmentation index. So what we found that in many of our patients, there were long periods of abstinence because, they are traveling and what all. So in those patients, we advised them to ejaculate every day. And on the fifth day of ejaculation, we took a repeat sample. And we found that the mean DFI had definitely decreased from 57, say, to 32 in these patients. And the DFI range was also in this range in those patients. So hence, basically what we found was that when you ask the patient to keep on ejaculating, before you label them as being untreatable DNA fragmentation, please try this method. Keep on telling them to ejaculate every day and then repeat a sample and then go on. It will definitely help. So such tests are now being devised and they do help. So again, now if you do not find an effect of any of these things, you don't find that the antioxidants are helping and ejaculation is helping, then what do? So you directly aspirate the sample from the testes. So what is said is the rationale behind this is that when the sperm passes through the tract, that is the time that there is maximum oxidative stress and the DNA fragmentation is increased. So therefore, you directly take the aspirate from the testes, you do a TESE, and then you basically use that for your IVF. And this was first reported in 2005, and later on it has been established as a method which is being very commonly practiced in patients where they have a resistant high DNA fragmentation index. In those patients, you are actually giving them this method to improve their chances of pregnancy. So basically, this is a paper which was published in 2010, and it showed that there was a threefold lower range of in the testicular spermatozoa as compared to the ejaculated spermatozoa in the DNA fragmentation. So this method is now become the standard method. So now what is the management therefore for this kind of a person? If you have high DNA fragmentation or sperm DNA damage, you will either give an antioxidant therapy and lifestyle modification, retest after 3-4 months. If it is not helping and it is abnormal, you do a testicular sperm retrieval and an ICSI followed by that. So this is now the standard method for managing a patient with abnormal DNA fragmentation. What about sperm selection techniques? Many of you would want to know this also. Many times we say, okay, we will select your sperm and put the best sperm inside. We will do ICSI with the best sperm. So how do you select the best sperm? What are the techniques that are available to define the better sperm as compared to the worse one? So the methods that are available are called PICSI, IMSI and MAX. I will describe these to you. PICSI first, IMSI first. Okay. Intracytoplasmic morphologically selected sperm injection, which means that you are picking up a normal sperm and basically then you are injecting the egg with that particular sperm. You look at it morphologically. So here is what you do. You have a very high magnification microscope lens put on the machine, and you can see over here, this is the 400x with which you see these small sperms. In this, you cannot define what is the head and the acrosome like, but when it is highly magnified, you can define the vacuoles, you can define any breaks over there, and then pick up the sperm which is looking the best, and then inject it, do the ICSI with that better sperm. This is the equipment. It is not very different. It is basically attached to the ICSI machine with an extra camera and a monitor to look at the sperm. This is how you measure the length of the head and then the mid-piece. And if you look at everything, there have been parameters described by which you define that this is a normal one or an abnormal one. Now, basically, sperm binding assay or IMSI or PICSI. So this basically is based on the hypothesis that hyaluronic acid is a major component of the cumulus and the complex which surrounds the human oocyte. So the sperm's ability to bind to HA is a biochemical marker of the sperm's maturity and the DNA integrity. So only the mature spermatozoa with developed receptors for the HA can bind. So therefore, they are actually selectively, they bind to the hyaluronan on that. So therefore, what we do is there is a dish, a petri dish, which is covered with this chemical, and you allow this, you put a droplet of sperms in that, and then you see what are the sperms which are sticking to that. And that basically will tell us that this is a functionally mature sperm. Therefore, you will pick up that sperm and then use it for ICSI. That is how this is used. This is the PICSI dish. And then you basically select the sperms which are binding to the sides of this dish. So basically this test study, which was done in 2012, it was a multicentric, double-blind, randomized controlled trial, which showed that in patients where you are having a problem with pregnancy loss, if you pick up the sperm, select the sperm, depending upon the HA binding, then you find a better pregnancy rate, and the pregnancy loss is much decreased in these patients, as you can see here. The PICSI is a standard treatment which is used in our NOVA labs for defining the best sperm. Then basically, so this is sperm binding and ICSI. You have these petri dishes where a drop of sperm is placed, like I said, and then you look at the migration of the sperms. This is what it looks like, as you can see, and then you just pick them up and use them for ICSI. What about magnetic activated cell sorting, or MACS? This is a new method which has just now come in. The principle is again that DNA fragmented sperms have an affinity for and are labeled by annexin V conjugated magnetic spheres. These are the spheres to which it gets attached. A weak magnetic field separates out the apoptotic sperm from those with the best treatment potential. So here are the ones which are sticking, and these are the ones which are better, and they are not sticking to that. So therefore, basically you rule out you take out the better sperms based on the magnetic activity of the sperms. So again, there were results which have been found that it improves the pregnancy rate by using this kind of a method also to select the sperms. This also is being used in NOVA. So we are using both these methods in order to do a sperm selection. How about patients who have azoospermia? Now, what do we do with these patients? You have azoospermia and patient is not willing to have a donor sperm. This is a very big problem. So what do? There may be various causes for it. We know that it could be an obstructive azoospermia or it could be a non-obstructive azoospermia. But the reasons for that are testicular, where you have all these genetic problems and infection and idiopathic also. And you may have a pre-testicular cause, which is hypogonadotrophic hypogonadism, as you had in the woman. So these are some of the factors which you have to think in mind when you have a patient of azoospermia. And what do we do for these patients when there is a patient who has azoospermia? He has no obstruction, the tract is clear, because when you do a fructose test, it is positive, which means that the duct is all right and the semen is being produced, only that there are no sperms in it. So microdissection testicular sperm extraction, or microtessi, is a method that has been described or defined as the standard technology for taking out sperms from the testes where you don't find any testicular sperm. So this is the latest option for the worst azoospermia. And basically, the underlying concept is that the seminiferous tubules will contain many germ cells rather than Sertoli-only cells, and they are larger in diameter and opaque than the tubules without the sperms. So when you look at them microscopically, you can find out the difference between the larger ones as compared to the smaller ones. And based on that, basically, we try to see whether we can take out. So sperm retrieval has increased from 45 to 63% after the introduction of this method in patients where you have non-obstructed azoospermia. So advantages are there are high success rates, larger number of sperms are retrieved. Disadvantage, of course, is that it is very expensive, time-consuming, and microsurgical equipment and expertise is required. Post-operatively also, the patient may have more discomfort as compared to the simpler methods. I do not know if this, yeah, it might work, yes. So this is a very beautiful video, which is showing, actually, this was given to me by Dr. Vasan. He's an embryologist also. And see, you can see here that the testes is being laid bare, tearing out the capsule, and at the same time pouring saline all over it so that it doesn't get dehydrated at all. And then gradually teasing out the seminiferous tubules, as you can see over here. This is microsurgical approach. And you will see that very soon they will be able to define the tubules over here and take them out. You can see that gradually This is being teased out, and we have our very, very successfully trained andrologists all across Nova who are practicing these techniques for us and giving us very, very good results. This is a method which is actually very helpful for patients where it is nearly helpless or hopeless to find sperms in. Very soon you will find that there will be a tubule which they will pick up from here, and after teasing these testes to a large extent, this is what, see, you can see that they have caught hold of a tubule now. You can see it very well. And then this tubule is sent to the lab, to the embryologist, who looks at it in the dish and then defines whether there is any sperm in that. And as soon as you find the sperm, that is used for ICSI. Some people like to do a fresh one, TESI, because when you freeze these sperms, you can again cause oxidative stress in those frozen sperms, which are defined as iatrogenic. Therefore, it is better to do it fresh. But the downside of doing a fresh TESI is that you may not find any sperms, and therefore the whole cycle of the patient is lost. You will have to freeze the oocytes if the patient is not willing for donors insemination. So that is the downside of doing it at the same time. But some centers prefer to do it before, and some centers like to do it at the time of ICSI. We are generally doing it at the time of ICSI in our centers, and we are our andrologists are so well trained that we generally do not fail in any of the patients that we have. We generally are able to get sperms out of them. So here are the results of IVF and ICSI, basically of various reports, which have, these are all old reports, but you have much, much better results now. This is according to the diagnosis that you have. You can have it after post-infection, varicocele, torsion, mumps, etc., etc. And you can see that in such patients also there is a chance of sperm retrieval in these cases. So what about then another major problem? Male infertility has been tackled by these new techniques. Now you come to the failed cycles. What do you do for failed IVF cycles? And you have repeatedly failed IVF cycles coming to you. You have to think of a problem for such patients as well. The most important thing that has happened over the years is the change in the type of patient, which I have been telling you again and again right from the beginning, is that basically you are now finding multifactorial infertility where both partners are affected and there are multiple failed cycles. So what we found in the year 2010 to 2015 was that the average age of our Indian patients that we were getting was to the tune of 25 and 30. And PCOS was forming a 25% of the bulk of patients that we were getting. Now what has happened is that the age of the patient has increased to 32 to 40, and the most important patients, or the bulk of patients, 50% of patients that we are getting now, are either poor ovarian reserve, premature ovarian failure, or unexplained infertility. So basically it is the type of patient also that has changed, and hence it is impacting our results also, because basically we do not know what best to offer to these patients. Whereas again, in male infertility also, the age of the patient has changed. You find that most of these patients are having an abnormal semen parameters with the advancement of age also. And like I said, DNA fragmentation is also to the tune of 30 to 40% in these patients. Hence, all these factors put together are leading to multiple failed IVF cycles. So basically what you do is to improve the endometrium. You are doing a personalized ET, also a personalized ET. And we talked about a personalized stimulation, a personalized luteal support, and now we're talking about a personalized ET also. And basically you are adding substances into the endometrium to make the growth factors better. So this test is done to determine when the endometrium becomes receptive, and it is performed on a designated day, and it gives rise to a better pregnancy rate. So these are some of the tests these are some of the reports of the same. A very important thing is pre-implantation genetic screening. This becomes important because most of our patients are now of the older age group. Hence, we have to offer this to our patients, and recurrent implantation failure also is more. So we have two types of genetic screening, the invasive and the non-invasive. The invasive is wherein you're taking a biopsy from the embryo, from the outer layers of the embryo, and non-invasive is where you're collecting the culture medium from around the embryo to see what it has secreted out. And based on what DNA you find over here, you assess the genetic screen, the genetic component of that embryo. So in both the cases, you're looking at the DNA and then assessing the genetic score of that embryo. So what about PGTA? These are some of our results. I will leave this again. Basically, aneuploidy screening has been a very, very important thing even in our cases. This is something which is very new, AI, artificial intelligence. As you all know, it is growing. And this is also something that we offer to our patients where we are using this technology and assessing the viability score of the embryos as well as the genetic score of the embryos. And based on that assessment, we select the best embryo and transfer to get a better pregnancy rate. 66.2% was what we found, and this has a very good correlation with our pre-implantation genetic test also. Lab improvements are because we have better KPIs and better QA and QC. We have standard operating procedures, like I said, and we are always monitoring everything in the lab, whether it is the incubator or it is even the embryologist. We monitor everything. So there is a standardization for all, and we have our own internal benchmarks, which is important to have a good clinical program. Blastocyst transfer is something that is being practiced in all of our NOVA SOPs. The benchmark is 40% and the pregnancy rate is to the tune of 38 to 52%. Third-party options in ART is something I wanted to talk about because basically there is a change in the ART law in the country. All donors are supposed to be altruistic and surrogacy is also altruistic now. Embryo donation is not allowed. Surrogacy is also, I'm sorry for this printing, but surrogacy is also altruistic now. So if you have to send a patient for any of these programs, you have to send either the donor with them or the surrogate with them. Oocyte cryopreservation is done for cancers, endometriosis, and social egg freezing. This is a huge program which is offered to normal patients now, not infertility patients. It's not restricted to infertility, but yes, it's a very, very big program which is being offered across, and it gives you very good results. Social egg freezing is for women who do not want to produce children as soon as they get married, or if they are not married, they want to preserve their fertility. So again, cryopreservation, we all do this, and 80% of our cycles are now cryopreserved. It is basically done for the same reason, and it is done by vitrification, which is a very good fast method. So here is what we have seen in our own results. In vitro maturation or fertilization is a very good alternative now, which is being practiced across the world, and it is coming up as a good alternative for poor responders or poor ovarian reserve patients, where you're picking up the smaller eggs, making them mature, and then using them for forming embryos. This is going to probably change the way ART is going to be practiced in the coming years. So what defines success in ART? Is it just the results? No. It is the patient satisfaction, it is the patient retention, it is patient recommendation and referral, and ethical and transparent practice, the reputation of being a good, honest practice. So this is our data from April 22 to September 23. We did about 22,000 cycles, 980, and basically giving a pregnancy rate of 59.5%. That means to the tune of about 60%. So we are basically trying to turn the dreams into families, and we are doing it the right way. As you can see, we have tried to be as ethical and as transparent as ever, and we have adopted all the new technologies. So thank you very much for being here with me today, and I'm sorry to have overshot my time. Thank you so much.
Ladies and gentlemen, that was Dr. Sonia Malik from Nova Infertility. She is one of the most celebrated IVF doctors in India today, and Nova is one of the most go-to place for an IVF treatment today. In case you have any questions, you can place it on the chat box so that we can see and read out. Till the time everybody is thinking what question to put in, or for all those people, most of you already know who we are. Ladies and gentlemen, my name is Abhik Moitra. You have seen me before, you have heard me before. I represent HBG Medical Assistants and Healthy Aunts. With me is my colleague, Dr. Kritika, who was the host for some time in this webinar. I thank you, Blue Health team, for organizing this, giving us yet another chance to present some of the superlative practices, medical practices from India. Thank you, all of you from Blue Health. We are very, very grateful. I need to also thank the Nova Infertility team, the team of Sriram, Anamika, Vikas, and obviously Dr. Sonia Malik herself. Madam, it was an excellent, excellent presentation. I have never seen someone presenting with such zeal and such continuity. Thank you so much. This is the last call for anybody who would want to put up a question. So somebody is asking, what is the price of the treatment?
I think you'll have to get in touch with our team. They will be able to explain it to you better, because I do not know what is the rate of conversion from your country to our country.
Let me give you an idea. So the rate of IVF treatment at Nova Infertility and in India per se ranges anywhere between $3,800 to $4,200, depending upon case to case. And in case there is any donation, egg donation or sperm donation needed, there will be an extra bit of cost that is added. Otherwise, it usually ranges between anywhere between $3,800 to $4,200. It also includes investigations and everything else. So that's the ballpark figure. It can vary 10% here and there.
Yeah.
Is it possible to start in Ethiopia? Madam, is it possible to start in Ethiopia?
Yes, yes. Why not? Surely. Surely it can be started. There shouldn't be a problem at all. I think the team can get in touch with you people, and between all of you, you can make a very, very good program. I don't think it should be a problem.
In fact, to answer everybody for this question, between Blue Health team and Ethiel Medical Center in Addis and HBG and Nova Infertility, we are trying to develop a program where at least for the time being, the initial steps can be taken in Ethiopia. I'm sure Dr. Binyam can throw a little bit of more light on this, but otherwise the plan is definitely there to start this program in Ethiopia. Initial agreement and everything has already been signed. We can definitely start, and soon you will hear from us. We will start this. Madam, can you share any success stories in a very small, monologue?
Well, it's interesting, Mr. Moitra, that you're talking about small ones with me. Well, you see, what is my problem with patients who are coming from abroad is, Abhik, I think you people will have to help us in that. IVF is a continuum. It is a continuum of pregnancy is a continuum of IVF. You know, when a patient becomes pregnant and goes back to, say, Ethiopia from us, that is the biggest problem. That is where you have to do a lot of hand-holding for this patient. And I think it would be very sensible if some of you can form a patient support group or with us. So I will prescribe a medication which is not available in Ethiopia, or there is something which is available and, we don't know about it. So if you are there to help us and we shake hands with each other, then we form a kind of a group wherein we refer the patient back to you, and you can, take that patient through pregnancy, because the patient cannot stay in India for 9 months. This is contrary to the other treatments that you have, So suppose there is a patient who has come to India for an orthopedic surgery or a heart surgery. The moment the surgery is done, they are cured. But here what is happening is, after an IVF, once they get pregnant, they have to be looked after for 9 months in order to produce a normal child. And those 9 months are critical, because these are high-risk pregnancies. You have to understand that any patient who goes through these procedures have some basic problem in them. That is why they haven't conceived, which makes them a high-risk pregnancy. And if you people can, sort of agree to this, and we can have specific names wherein we refer the patients to so and so, it will become very, very easy for us. I think, Mr. Moitra, you, more than starting an IVF center, you should try to do this before you can really get a good center going. There have to be people at your end who will be able to help these patients. That is my short story. We find a lot of pregnancy loss. We find a lot of pregnancy loss happening once the patients go back to their country. That is what is my problem. Pregnancies do happen, but they have to be retained. That is why I'm saying that we have to all get together. And with these webinars, I'm sure we can all know what we want from each other. And therefore, we will try and make it into a very good cohesive program rather than just doing it in, a sort of silos. This one is doing this, that one is doing this. No, it has to be a comprehensive, cohesive program. That is my take on this.
Dr. Binyam, can you throw a little bit of light on the program that we are devising along with Dr. Lemmy?
Yes, Mr. Abik, thank you for the chat. So currently we are trying to incorporate the infertility treatment that has been done in Ethiopia to do the infertility treatment in overseas in India with the help of Mr. Abik and ITEL MCH clinic here in Ethiopia. So we are on the process of getting our first patient sent to India. So the process is being done in the coming 2 months.
What will happen is the pre and post. What Dr. Sonia highlighted was the handling of the patient after the procedure has been done and during the pregnancy. And this is exactly, Dr. Malik, that is what we are trying to do, handling the pre and post along with, so the team of doctors from Ethiopia will come to you, they will get trained alongside you to handle the pre and post part of it. So that our success rate can become better from what good it is. I don't think there are any other questions. In case you do have a question, ladies and gentlemen, you can always send your question to the Blue Health team, which will, with help of Dr. Sonia Malik, would answer. Dr. Malik, I will take this opportunity to, on behalf of HBG Medical Assistants, Healthians, and Blue Health team, to invite you over to Ethiopia to make a physical presentation, have a look at our centers that we are trying to build, and assist us to make this program even better. We cannot do it without your assistance. It is our humble request to do take a couple of days and visit us and help us build this program in times to come.
Thank you so much for the invitation. I'm sure we'll be able to do something together. Thank you so much for inviting me. Thank you.
Thank you, Dr. Malik. I will take this opportunity to thank Sriram and Anamika and the entire team of Nova Infertility, which has helped us to organize this webinar. And I will also like to thank once again Dr. Sonia Malik. Over to you, Blue Health team, for your final words.
All right, thank you so much, guys. Dr. Sonia and Mr. Abik, Dr. Kritika from the HBG team and from Nova also. It was an amazing presentation. On behalf of our participants in Blue Health Ethiopia, we would like to thank you all, especially to Dr. Sonia. It's a pleasure having you here, and hopefully we'll meet in person soon.
Thank you so much. Thank you very much for having me. I have enjoyed myself.
Thank you.
Thank you, everyone. A big namaste from India. Hope to see you all soon. I have requested Blue Health to already organize another CME like we did in the month of July. Hopefully, we will get to see you all soon, very, very soon, physically. Thank you, everyone. Have a good night.
Have a good night.
Good night to all.